All right, everybody, welcome. Good seeing everybody on the group here today. We appreciate you taking the time to join today's session. My name is Jay Mason. I'm going to facilitate the session. I'm with Project Echo through the WVCTSI. For those who have just joined, make sure to put your info into the chat for attendance and introductions. Again, we're looking for your name, your email, your organization, and your credentials. So we appreciate you doing that. We're going to have a full session today. We've got a didactic presentation. We have a topic discussion as well. And then we'll do some wrap up at the end and look ahead to the next session. At any time, if you have questions or tech issues, anything like that, please use the chat. You can either private message me if you have a tech issue, or if you have a question at any point, please throw it in the chat. We'll be monitoring it. Also, go ahead and use that raise hand feature at any time as well if you'd like to make a comment or have a question that way. We are recording it, as you know, and we'll be posting that on YouTube and sending it out in the recap. So if there's any part you need to go back to, you'll be able to do that. Are there any questions before we begin? All right, then we will go ahead and get started. Stephen, you are up first. So if you want to go ahead and share your screen, introduce yourself and take it away.
Sure thing. Give me just a minute here to get on. There we go. Okay, is everybody able to see my screen?
Looks good.
Okay, outstanding. It's a good Tuesday afternoon. I might even go a step farther and say maybe happy early spring. At least it feels like it out there today. My name is Stephen Perry, and just to clear the air so that there are no questions later on, yes, I am that Steve Perry. I sing for a band called Destination, and we've charted lots of hits. Most of you probably know us for our hit song, Keep on Hoping. And when I'm not selling millions of records, I'm also a social worker, sometimes student, and I am the all-the-time director of training and development for First Choice Services here in Charleston. We're actually probably the largest single host of a host in the state for behavioral health, substance abuse, and addiction hotlines. And some of those we're going to get into today, but the one I'm really glad that you invited me to talk about with you today is the 988 suicide and crisis line. First Choice Services is not only the West Virginia host for 988, but we're also, a lot of people don't know this, we're also, as of last year, a national backup center for chat and texts, meaning that we also take crisis calls, chats and texts from all over the country. And while I can speak for myself in that I'm grateful to have employment, it is unfortunate that it comes along with so much pain, so much grief and sadness that thankfully buffers like 988, unfortunately though, have to exist in order to help people protect themselves from making potentially irreversible, often fatal decisions that we know can affect so many others beyond the individual. So this afternoon, we're going to spend some time talking about mental health here in West Virginia, as well as the nation, the gravity and scope of this problem, and how our society that has become increasingly more distressed, more sad, more isolated, more lonely, the impact that has had in the representation of suicidal thoughts and behaviors. We're also going to spend some time talking about what the mental health landscape in West Virginia, what that looks like. Most of us on this meeting today probably already know that it's not great. Despite being small in size, West Virginia has a very high percentage of its residents reporting mental illness. And often these go untreated because of cost or location. We have over 700,000 of our residents that live here in West Virginia that don't live close to or have enough mental health providers in their community. And almost 48% of our residents report not getting mental health care because of the cost alone. So in that regard, 988, it kind of exists as a little bit of a stopgap here, which leads to the next topic that we're going to spend some time on today, the vision for how 988 is going to be employed as maybe a catalyst for change in mental health and crisis response here in West Virginia. We're already starting to see this in other states, particularly in rural states where there is a continuum of crisis care and collaboration between first responders and 988. We're going to spend some time talking about the mental health of students and young people. Naturally, that's what we're here to talk about today, right? As well as what resources and supports are out there for them and how you can help make those connections on their behalf and with them. So if there's no questions or concerns right now, we're going to go ahead and forge ahead. So I want to start with some sobering stats. I'm not going to get into the factors that, could or maybe do contribute to declines in mental health. Most of us probably know the usual suspects, but maybe some of us don't know how pervasive mental illness is in the United States, because it's not always, it's not always an illness that we can see. In 2020, the data shows that someone was dying by suicide every 11 minutes. That same year, suicide became the second leading cause of death for our young people, young school-aged people between the ages of 10 and 14, 25 and 34. So yeah, even our younger folks in the workforce too, people who are just at the beginnings of their life, the beginnings of their career. But bear in mind, most studies show that the actual number of suicides is between 5 to 25% higher than what's actually reported, because see, reporting standards, these vary from state to state. And we don't always know what was going through someone's mind up to the moment of death, whether it was intentional or unintentional. So think about this in the context of overdoses, for that matter. We work closely with those in addiction and recovery here at First Choice. Practically all of our hotlines touch in this community. And I can say from experience the hopelessness that comes with addiction. I've heard so many people say that the addiction and the sadness of not being able to stop the use of that drug or that substance can and will eventually lead to a lethal indifference. And we see this reflected in the data here, with 107,000 deaths from overdoses in 2020. These, though, as we've established, aren't always counted as suicides, just like someone who maybe takes too much of or stops taking a medication, particularly if it's a life-sustaining medication like diabetes medication, heart medication, if it's going to kidney dialysis. If somebody stops these procedures, if somebody stops that treatment, that could in fact also be a suicide, but it wouldn't be reported as one. Also, suicide, as it relates to the population that we're talking about today, the #1 cause of death among college students. And again, we really could spend a lot of time talking about the unique stressors that students deal with. I was dealing with some myself last semester as a doctorate student, and realized at that moment, like, hey, I need to take a step back. I'm getting maybe in a little bit over my head here. So I've been there myself, even just as recently as just a few months ago. But the fact is that the numbers justify having supports and resources available to mitigate against the risk of suicide. Now, let's see how some of these same metrics vary out here in West Virginia. In 2020, we see that suicide was the 10th leading cause of death here. But we also kind of keep along with the national trends in that suicide is the second leading cause of death for our young children here. We also, despite our small size of less than 2 million people, we rank 8th in the nation for suicides. Now, I'd like to put a pin in these numbers for just a minute, because when we consider the youth representation, and we know that this includes kids in foster care, and also that the risk of suicide is higher, especially for those youth who identify as gay, lesbian, bi, trans. Consider then that West Virginia actually has the highest per capita percentage of trans youth in the nation. And suicide, unfortunately, it's the #1 cause of death among these kids. And they are kids. That's what we're talking about here. Kids between the ages of 10 to 17 years old who identify as trans, gender nonconforming, gender diverse. And a disproportionate share of them, sadly, are going to die from suicide, due in part to being denied gender affirming care, discrimination, emotional support, nurturing warm social relationships, and ultimately a culture that values them, that accepts them, sees them, welcomes them, and includes them. So as I mentioned, 988 as being this kind of stopgap for life or death. I think it's important that we remember that 988 is not a fix-it-all. It's not a one-stop shop. I often tell our crisis counselors, once this person ends the phone call, ends the chat, ends the text, their problems, and a lot of people call us with a lot of problems, or they reach out with a lot of problems. Those problems are still going to be there. They don't suddenly get better. But what 988 does is it provides an opportunity or a chance that things could get better. How often, have you or any of us on this call today, how many of us have thought, that, well, this is the end of the road, or, this is the end of my wick here. I can't go any further. There's no other option. There's no way forward, only to find that after, a good night's rest or a meeting with a friend that, oh, wow, there was this other route. There was this other option. There was this other way I could have went and did go. Or the fact that, maybe once upon a time you were thinking about suicide and you didn't move forward with that, and all the great things that have happened since then, all the wonderful experiences that you wouldn't have been able to have. And so that's really what 988 is about. It's about the ability to stay safe for now so that you can have hope, so that things could get better. And we help thousands of people overcome crisis situations every day. The numbers really are, they're pretty big. And I'll go into a little bit of detail in breaking those down in terms of how many encounters, chats, and phone calls we talk about every day. And it's proven to work. This approach to not, choosing life or death, but simply a third option of choosing to be safe for now. Studies have shown that this helps people be less depressed, less suicidal, feel less overwhelmed, and ultimately more hopeful by the end of the conversation. So where did 988 come from? I'm not going to insult anybody's intelligence by reading all of these stops here to you. But this really it's been a slow march over 20 years. We can see that, when Congress approved the money for a suicide prevention hotline, we're going all the way back to 2001 here. And then slowly different pieces, different components of this starts to get added. We see a designated phone number. We see that a veterans crisis line gets added. We see that disaster distress helplines are added. We start to see that the FCC in 2020, they designated 988 as the new 3-digit phone number. Because as it turns out, sometimes it's hard to remember long, laborious phone numbers when we're in a moment of crisis, when we're feeling frustrated and overwhelmed. It's a lot easier to remember 3 digits. Most of us probably can't remember the first phone number we had when we were a kid, but we definitely remember being in kindergarten and, maybe the police officer or, the fire chief saying, if there's fire in the house, call 911. And then, this goes on into, capturing that data, additional funding being released and planning grants going to Vibrant. This is one of the agencies that we collaborate and also get a lot of our funding through, who helps to develop a lot of the best practices that our crisis counselors use. So when we're talking to someone who has thoughts of suicide, we're not just going at this willy-nilly and just, hoping that a pleasant conversation with a close friend is going to be enough to pull this person back from the edge. No, we're using evidence-based practice, evidence-based skills to de-escalate and identify buffers, supports that can help this person choose to stay safe while also being able to assess immediate risks to safety. So how does it work then? Well, according to the latest data that we have available on record in 2021, there was over 3.6 million contacts through the Lifeline. And people who call the Lifeline, they come in and they are provided a brief questionnaire at the beginning, including, are you a veteran? Do you speak Spanish? If so, there's options available for that. And once you choose that option, you're going to be ferried out to the correct destination. And you're also going to be able to talk to, if it's calling phone calls here in West Virginia, you're going to be able to talk to a local crisis center. Now, if it's chat and text, you might get someone who's, working in California, or you might get someone who's working in Portland, Maine. But one of the cool things about calling Lifeline is that you're talking to someone from your community. You're talking to someone from the neighborhood. I've found in my travels, oftentimes West Virginians, we're not even 6 degrees of separation. I've run into West Virginians in Alaska. I've ran into West Virginians in Peru. It's the weirdest thing. And then you start talking, you're like, hey, do you know such and such? Yeah, I know them. And there's always this weird connection that exists. And so with that in mind, it's very likely that you're talking to someone on that line who probably knows you through someone who knows you. But as I mentioned, people who text and chat the Lifeline, they're going to be connected to centers that are equipped to respond to those. And that could also be West Virginia. We are, again, a backup chat and text center, and we receive anywhere between 100 encounters a day, Monday through Thursday, and then up to 200 encounters per day, Friday through Sunday. So that number, it tends to fluctuate, especially on the weekends. We start to see a little bit of an influx, and really a lot of those numbers, within those numbers, is reflected a shockingly high percentage of young people between the ages of 10 and 24. Our West Virginia call center, we receive anywhere from 30 calls a day or more. And being that the need is justified, we're hoping to make 988, like a lot of other counties across the country have done, particularly rural counties, have been able to incorporate 988 as kind of this catalyst for changing their continuum of crisis care. So right now, we're actually in the process of hopefully building a bit more of a productive relationship with dispatch, 911 dispatch, fire, EMS, and police, as a way to help identify what are mental health crisis encounters and make those distinct from what are emergency encounters. So you can imagine that, let's say someone contacts 911, and how often is someone contacting 911 and it's not a fire or legal or medical emergency, it's a mental health emergency. But it's not always that the fire department, the EMS, or the police officers are trained to de-escalate a mental health crisis. And so that would be instead a response that's appropriate for 988. How about being able to, that 911 dispatcher being able to then transfer that call over to 988 and handle that appropriately? Or potentially in the future, maybe having, a mobile crisis counselor being able to go on site and out into the field to handle some of those low acuity needs that might require a softer touch in addition to a maybe medical or legal touch. You can imagine lives could be saved, lives could be improved, and ultimately traffic in the emergency room could be substantially reduced if we're able to somewhat reduce the amount of people and bodies going in and out of the emergency room that could be better served in the community. So there's a number of different ways that using 988 immediately sort of connects someone with a network of different resources. So yes, if our 988 counselors, they are trained to provide de-escalation. They're trained to provide immediate suicide intervention and be able to identify what those signs and what the presentation is of someone who's thinking about suicide and might not even be aware of it. But sometimes we also have to accept that, particularly with our younger people, they might have special needs. They might have very special circumstances that require a different touch. And one of the great things that we definitely enforce here on 988 is that this is kind of a pathway into a wide spectrum of mental health services. So let's think, college freshmen, or, maybe the high school senior or middle schoolers. We can actually talk to you as the middle schooler, high schooler, or college freshman, but sometimes it helps to talk to a peer. Sometimes it helps to talk to someone who can speak to that experience. And so we can help aid a warm line handoff over to Teen Line. That's through Dee Dee Hirsch out in Los Angeles, California. You can see that number here, 800-852-8336. Folks can also text that number as well, 839-863. Here in West Virginia, you see the number 4 here. That is the symbol for Help for West Virginia. Help for West Virginia is our state's largest substance abuse and addiction hotline. This is a gateway into all of the different resources for substance abuse, mental health, and also the state children's crisis and referral line for behavioral health. So if you or someone is looking to get into a program of recovery, is needing to get into an inpatient or comprehensive behavioral health center, you would want to reach out to Help for West Virginia. And being able to call 988, we can simply aid with the warm handoff to one of our friends up at Help, simply by calling 844-HELP-4-WV. I might have addressed this group once before when we were talking about Help 304 following the COVID crisis, which seems like it was forever ago, but then every once in a while it kind of appears back in the headlines and we remember that it's still there. But Help 304 is free crisis counseling. In other states, these go by the name of warm lines, friendship lines. This is a free resource available to anyone across West Virginia, particularly students who maybe just need 10 or 15 minutes, a half an hour, whatever, to get some things off of their chest, to talk to someone else who's willing to listen, trained to listen, and provide some insight and reflection. And that number is available 24/7, 365, 877-435-7304. There's also a number of different community-specific hotlines too that folks can access through 988 if they ask for them. The Trevor Project, this is for young people who identify as LGBTQ. They can talk to someone from the Trevor Project by calling 866-488-7386. They can text START to 678-678 or chat at thetrevorproject.org. No doubt, of course, again, kind of the gateway to all of these different resources is through 988. And that number easy to remember. I would hope it's easy to remember at this point, is 988. Another cool thing that people don't always, that I think doesn't get the advertisement, is that that number can also be texted. And you can also just type in 988 on google.com and immediately get in touch. You don't even have to go to the website. Just type in 988 and Google will immediately get you in touch with a crisis counsel. So you can chat online that way. There's the National Eating Disorders Association. That's available. If, talking to a peer who struggles with disordered eating, someone who has that experience, that can be really, really relevant when dealing with a mental health crisis that's, maybe resulting in some disordered eating habits. That number is available. Call or text 800-931-2237 or chat nationaleatingdisorders.org. And I do want to say that APA.org has a number of different helpline resources, toolkits available, and that's just APA.org. There's tons of information available in there, and you can even source it and index that by state. One of the apps that we use when we're working with folks who are dealing with thoughts of suicide and helping them develop coping strategies, coping techniques, safety buffers, is an app. It actually overlays with our call reports pretty even-handedly. And folks, whether they're calling 988 or it's something that they want to do on their own, can go to the My3, that's the number 3 app.org, and write out for themselves and have emailed or texted to them a safety plan, something that they can refer to, a living document that someone can refer to when they're in the midst of a mental health crisis. And one I actually just found out the other day, but I was really excited about this one, and it's super salient to what we're talking about right now with students, is Grad Resources. This is another hotline that is specific for the needs of students. And that number is 877-472-2457, specifically for mental health, test performance anxiety, a lot of the frustrations that come with being, a university or community college or even vocational school student. There's a lot of pressures put on there. Lastly, one thing that I just want to hit is very quickly sort of what goes into developing a safety plan, what goes into developing resources and supports that someone can quickly refer to when they're dealing with a mental or behavioral health crisis. 3 words we want to remember. We always want to remember this: available, approachable, and able. That resource, whatever it is, it needs to be available to you. And a 988 or any of our helplines are available 24/7, 365 days a year, including holidays and weekends. The resource, it needs to be approachable. Someone who's comfortable talking about suicide. And again, 988 crisis counselors, they are trained to talk about suicide with anyone from any population, from any community, from any walk of life. They're going to be able to provide an intervention to keep that person and help keep that person safe for now. And the resource needs to be able, needs to have some acumen, some ability to talk and provide an intervention to keep someone safe from suicide. And all of our helplines are actually trained in these interventions, including Safe Talk, applied suicide intervention skills. And more recently, we've even started kind of getting into the areas of QPR. So let's look through these again. Some personal resources that folks might refer to when building out their safety support network. Someone they can confide in. Oftentimes we'll tell folks, who are answering the lines on 988, let's not immediately look to friendships or family members. Sometimes that in itself can be really painful when we're feeling frustrated or sad and alone, because it could be our family that is maybe sort of the dysfunctional component, or sometimes it can be really hard to think of friends when we're feeling sad and alone. So I'll often use the approach of, let's say you want $1 million. Who's the first person you're going to tell? Or maybe you needed to make a really important decision. Who are you going to ask? So someone they can confide in. This might be a therapist. It might be a counselor. Maybe if that relationship needs to be reestablished, include that in the safety checklist. Could be family members. Could be a romantic partner. In some cases, if somebody's coming to you on campus and they're dealing with thoughts of suicide, you might be that person. You might be their most immediate buffer to protect them from suicide. Also, let's make sure that we're including 988, that we're sharing that as a resource. That's available chat, text, or phone. Any of our other helplines that you see on the screen here, these are all free and available to anyone 24 hours a day, 7 days a week. That includes Help for West Virginia, Help 304, 988, our problem gambler, and the one on the bottom right there, which I do want to just stop on that just for a second. That's our West Virginia Navigator program. And that can help get people signed up for insurance free of charge through the West Virginia Medicaid program, or if they don't qualify for Medicaid, we can find them an affordable marketplace plan as well. And I'll show you these numbers in just a second. Let's not overlook religious leaders. West Virginia is a very religious state. A lot of us probably grew up going to church. Mental health facilities. And lastly, if the risk is immediate and there are very critical threats to safety, of course, 911. Those numbers again, though, for our first choice services, 844-435-7498, that is Help for West Virginia. Free crisis counseling, 24 hours a day on Help 304, 877-435-7304. 988, probably the easiest crisis number you'll ever need to remember. Chat, text, or call 988, or just Google search 988 and you can actually get connected to a crisis counselor that way. Gambling, it's one of those addictions that tends to get overlooked a lot of times because nowadays it's kind of socially condoned, particularly as we're going into Super Bowl this weekend. The commercials have been hot and heavy for how to separate you from your money. So if somebody gets in over their head, naturally that can cause a lot of stress. 800 Gambler, and then of course our West Virginia Navigator phone number. Get signed up for Medicaid or Marketplace Plan, 844-982-2737. That's all I've got. I guess I will stop sharing my screen right now. But if anybody has any questions, that is my email at the bottom of the screen there, Stephen Perry at firstchoiceservices.org. And I will, I think, turn things back over to Jay.
Stephen, thanks so much. That was great. For everybody that's on the call, don't worry. We'll make sure you get all the numbers and everything like that. So hopefully you weren't, writing them down so fast trying to keep up. You'll get them. Don't worry. A lot of great information. But yeah, let's open it up for questions for sure. Chat, unmute, and just start talking. However you want to do it. I saw Sam unmuted, so I don't know, Sam, if you want to get us started. If you had a question or a comment.
No, I didn't know when you wanted us to present our example.
Okay, well, I thought I'd just put you on the spot. We'll get to you here in a second. Does anybody have any comments, though, or questions before we switch gears? A lot of great info. No, it was a lot of info in a short amount of time. Anybody have any comments? Stephen, I have one question. This is just me being not involved in any of this. It's just the amount of people that are involved in 988 in West Virginia. I can't remember if you said the number. How many, like, in West Virginia? I know you can get connected potentially outside of the state, depending on when you call, text, or whatever. But do you have that number? Do you know how many people are actually involved in that?
So as far as those who are answering the calls, chats, and texts, so there are other behavioral health centers that do pick up those lines. But I can speak for First Choice Services, and we are probably, I would say, closing in on over 70
Okay. Wow.
Over 70. But again, certain behavioral health facilities, they have their own crisis programs that will take calls, that will take crisis calls. So really, I think the number could in fact be a lot larger and probably is.
Good deal. No, you talked a lot about other resources, and I just didn't know what that 988 resource meant to you guys as far as the numbers. So that's good to know. Appreciate it.
No problem.
Saw a couple comments in the chat thanking you for the information on hotlines and things like that. So again, we'll make sure we'll get those out. But we'll ask just one more time if anybody has any comments. If not, we'll switch gears though and get to the topic discussion. All right. Okay. Let's see. Sam and Rebecca and Kendall, I see all three of you guys are on. Thanks for joining. I'll let you guys introduce yourselves. I will pull up the case to kind of or the topic discussion to kind of walk us through. And then we'll have the Q&A afterwards. So just give me 1 second. All right. Is everybody able to see that? Seeing some head nods. Okay. Well then, Sam and team, I will turn it over to you guys.
Yeah, hello. My name is Sam Wilkinson. I'm the PI for the Regional Transition Navigator Services effort. This is a new effort that works with individuals aged 14 to 25 throughout West Virginia who have histories of substance use or severe mental illness or homelessness, either experienced or feared. So obviously that tends to be a pretty wide assignment that we've accepted, and we work with, again, individuals across the state. And I was hoping that we could have a conversation, and Stephen, I'm hopeful that you're willing to be a part of this, of when some of our clients should really think about being in touch with a service like the 988 versus when we would continue working with them ourselves. We've tended to think of these kinds of crisis lines as sort of emergency lines, but in your presentation, it sounded like that we could involve them much earlier in our process. I should also say I'm joined by my two teammates, who I'm very sorry I forgot to introduce: Rebecca Glettner out of Barbersville and Kendall Stokes out of Beckley. I'm out of Morgantown. Sorry for passing that over, but Stephen, are you in a position to talk to us a bit? And I can present our individual if that would help to contextualize what you might tell us.
Yeah, sure, absolutely.
Okay, so this is a composite of several of our clients. Just so everybody knows, this is not a single person, although what I'm describing is fairly common with the folks that we have referred to us. So this is a 19-year-old who's living on her own, has no contact anymore with her biological family. It didn't work out for reasons good and bad. This is somebody who's indicated to us that they need mental health, or they need mental health services, but they don't have support to actually go and get them. So they've explained that in several ways. They're unaware of services that are available. They're unsure of how to pursue services. They've indicated that they've attempted to medicate themselves through their mental health challenges. They've also indicated that they don't understand the severity of their challenges, which to us in our work communicates that there's been an acclimation to the mental health condition, as it were. And finally, this is somebody who does not have a lot of positive activities in the community that they're living in. Now, we would think I previously thought if this person was in crisis, we would start to think about a 988 call, something like that. But would this be someone that we could put in touch with you much sooner in that process?
100%. So once you've established that there's not an immediate risk to safety, or in the case that there is an immediate risk to safety, I never want to undermine the critical aspect of being able to physically be in a room with somebody, to talk to someone, and to have another warm body there to interact with. But if if it is an issue of distance, if this person is in a place that's not where you are and you're needing to make that connection, and to get, the sense of, de-escalation and get this person to a baseline to where they're able to think at least with a more rational mind, then getting that person over to 988 would absolutely be appropriate. First off, what we're going to be able to do is we're going to be able to, in real time, be able to measure what this person's risk for suicide is, and what resources, what buffers, and what strengths they might have available to them immediately, just in terms of, I think employing a strengths perspective, what they can use, what they can rely on to keep them safe, and then building as a part of that safety plan, some different resources that we would want to connect them with. Now, in the regards to the 19-year-old with, someone who's living alone, needs mental health support, doesn't have any physical support right now, they're unaware of the services, they're self-medicating, indicating that there might be some substance abuse issues. What we can do is, once we've been able to establish that this person is safe from suicide on 988, we would maybe then suggest, hey, there were some other areas that you had mentioned to me that were kind of important, and we might actually have some ways that can, and some different resources available that could get you to your next phase, to get you to your next point. And that one, the immediate one that comes to mind is through Help for West Virginia, which hosts the State Children's Crisis and Referral Line. And that is a hotline specific to the behavioral health needs of children up to the age of 24. And this is going to pair this client up with somebody who specializes in resources specific to the youth population. So this is going to include behavioral health centers. This is going to include congregate group homes. This is going to include information available on addiction treatment and recovery centers that take in young people, as well as detox centers, and also those facilities that house medical detox and inpatient as well. So in that manner, then yes, somebody who contacts 988, we can really kind of keep this in-house without having to send them physically someplace else, because that can always be really frustrating. Okay, we're going to give you another phone number to call or another place to send you. No, instead, we're going to handle it here. And a lot of times we can actually get this person in a place to where, if they don't have insurance, we can also take care of that end. And then we can maybe arrange for transportation as well through Link Care.
Both Rebecca and Kendall have more immediate experience than I do in working some of the facilities that you're describing there. Kendall came out of, why am I blanking on this? FRMS?
Oh, you're good. I came from FMRS, but I was working for Prevent Suicide West Virginia. So actually, I'm pretty familiar with the 988 and kind of what you guys can do. But yeah, I worked along with their crisis team and that sort of thing.
And then Rebecca worked for Prestera out of Cabell County.
Yes, I was a crisis worker at the crisis unit in Guyandotte, where they do the detoxification and a lot of the mental hygienes are processed.
When it comes to our client that we've described here, one of the sort of walls that we've run into with this individual is them telling us simultaneously that they have what they describe as dark moments, which prevent them from leaving the house, but also that they do not want to go to a facility. It sounds like if this is a person who's willing to make a phone call, maybe if they're willing to talk to us, they could call some of the resources that you've described to maybe pursue additional, at least communication about the dark moments that they don't identify. They've said that they have these. They said that these dark moments prevent them from leaving the house, but they've also said, indicated when they're describing them, that it's just part of life, that some days are like this and, there's nothing to be done about it. But that has often been rooted in, they don't want to go and talk to a doctor. They don't want to go to a hospital. They're afraid they won't get back out if they go. It sounds like these phone calls could be a sort of productive way to pursue at least distant mental health, I don't know if care is the appropriate term, but interaction. Would that be fair?
Yes, absolutely. And one of the things that we always, at least in training, that we advise against is we advise against what I believe is the worst advice of all, and that is advice. It's probably occurred to your point there, Sam, that it's probably occurred to this person that therapy does exist, that psychology does exist, that hospitals exist. But simply telling someone, go do these things isn't really helpful. What is helpful, though, is having a conversation around collaborating about, okay, how do you see working these problems out? What do you think would be helpful for you? And with us having sort of 988 as kind of that lever, sort of gateway to this, vast sort of ocean of resources, is that we can say, okay, so what I'm hearing from you is that maybe you're not really interested in going to an inpatient program, but you would be willing to maybe talk to someone about going outpatient or setting up perhaps some Zoom therapy sessions. As it turns out, I have someone here from, we'll just say for grins, I've got someone, I can conference in someone from West, from Seneca, or I can conference in someone from FMRS who can talk to us a little bit more about the scope of services that they have and what might be a good fit for you. And I also have the ability to continue to stay on that line until that young kid, that 19-year-old girl, tells me that she's, hey, I think I got it from here. Thanks for hanging out with me. I'll call back if I need you.
Okay, well, that's certainly very helpful. That's another, arrow in our quiver here in terms of how we work with the clientele that we work with, who are often, for good reasons and bad, pretty oppositional to the idea of pursuing interaction with institutions. Our program here is designed as a bit of it's not the last step by any means, but the idea is that we reach out to people who have rejected other more formalized institutions or care or opportunities than the work that we do. And so knowing that there is, even though I'm sure behind the scenes it's very formalized, but the act of making a phone call is making a phone call, something they are familiar with, something they are comfortable with, something that perhaps does not feel the same as interacting with institutions that they otherwise aren't interested in or don't trust. I would be interested in what other folks on the call would do with a client or who's somewhere along this line of identifying pretty strongly that there is an ongoing mental health concern without explicitly identifying it as a mental health concern or something worth pursuing, in terms of their acclimation to this as a standard feeling that they should just be used to. All right, well, from our perspective, I think incorporating the resources that you described there, Stephen, is going to be very helpful for us as one more avenue that we can pursue for folks that are really struggling with some of these particular challenges.
Happy to be a support.
Anybody have any further comments? Caroline, yeah, go ahead.
I was just going to say, I think one of the resources that Stephen touched on was specific to peers and the support that peers can give. And I think the one you mentioned was around eating disorders. And this is something I've really been seeing a lot. I'm sure many of you have as well in kind of the national coverage of campus mental health and collegiate mental health about the increase of training of peers to provide support to each other, specifically for students like this that are more reluctant to seek out maybe the more traditional services available on campus for mental health. And I've even heard it talked about recently as
the only path to go, not the only resource that we need, but the only path to go to try to address the huge level of need that's happening on campuses without just hiring more and more and more counselors, which we also need. But I'm curious if anybody has any thoughts on that and any thoughts on the expansion of using peers for some of the support that Sam was talking about this student may need just around pro-social activities and coping with kind of everyday life.
Don't be shy now. We know that there are some answers out there.
Can
Go
you
ahead, Jamie.
can you
Is it-
rephrase the question again? Because I just kind of keep getting lost in these like long questions. Can you just rephrase it one more time?
I'm not sure if that was for me or Sam, but my question was just what people's thoughts might be on using peers. So training peers to provide support to other students.
I think it's a fantastic idea, but I think we have to get some kind of framework in place before we even attempt to roll something like that out.
I'm sorry, my audio cut out. Did you say rule out or roll out?
Roll out. Like
Thank you,
transform-
sorry.
Yep.
Is just for this, is the frame, would the framework, if we're just talking here, if we're just different parts of this process talking, are we thinking about a framework that might be analogous to recovery coaching?
I mean, any framework would exist. I mean, just for example, the Green Bandana Project kind of touches on this, but what is the standard for training for green bandana layers or levels, for example, right? So it's 1 hour of training versus 10 hour of training versus 50-hour training all on the same level, or are we going to have a framework that says this makes you a peer coach after you do X?
Do the folks on this call have experience with, I mean, a lot of you are, I think if I'm understanding it correctly, mental health professionals of various stripes at various institutions. You're encountering people after the acceptance or identification of mental health issues, or is some of your work focused on helping people to understand that there is a mental health issue that may be playing in their life?
I'm a counselor at Shepherd University, and I think it's what you're kind of talking about is kind of like we work with students that don't quite know the symptoms that they're experiencing, and they're not quite sure if it meets like a criteria of having a mental health disorder. You know, we meet students with where they're at, and there's some ambivalence of kind of like diagnosing, and we have, you know, students that want to diagnose themselves with something that's much more severe than what it is, or it is actually a severe condition that they're experiencing, and we just work with where they're at. Some of the things that I thought of when I was listening to this case was it's just really, really important to just try to connect, because we don't necessarily have to have all the answers, but the most important thing is just trying to really establish connection. And as you're connecting with that person, you figure out ways to provide education. So when I'm providing education and just giving a little bit of kind of some education, but also focusing on connection, I think that that's much more impactful than quickly just trying to be like, here, go to this person, because in instances where we feel really, really overwhelmed when we don't have options and we think it's only one path, we miss the point of connection and a long-term solution. So hopefully that was helpful.
Yes, indeed. Thank you for that.
Well, we got about 4 minutes left. We have a couple of questions for the group as a whole here that we want to ask. So Sam, Kendall, Rebecca, we really appreciate the time. Hopefully, you got the information you needed. We'll also send some notes that we've taken as well, so you guys hopefully don't miss anything that you heard today. But we really appreciate you joining and presenting today. So thank you.
Thank you for having us, and we enjoyed being
Yeah.
here. Sorry, I just wanted to touch in. Thank you, Stephen. I did enjoy the presentation though. I like the collaboration too, so I'm happy to be here and learn about what everybody else has going on and the resources that are out there. So thank you guys.
Great. And thank you, Carolyn, for putting the next session in there. It's going to be March 7th. And so same time, same Zoom link, everything. And then also we did get some feedback on the last evaluation about potentially doing breakout rooms for the discussion topic. So for instance, today Sam goes through the individual or the composite of the individual, and then we would break out into maybe 2 to 3 breakout rooms and have that discussion. Do we think that's helpful? Is it better when we're all in the same room and we're getting the links and things like that? Because that would be a little funky, because there might be links shared in other breakout rooms that you might not see. What are people's thoughts on that? Just off the top of your head. Like it, hate it. It's okay either way. Like the breakout idea? Okay, Jamie, thank you. Okay.
Yeah, I think it's worth trying. I mean,
Okay. Sure.
since there seems to be some kind of barrier for people speaking, perhaps in a larger group where people would rather.
Oh, you went on mute there, Jerry, the last part.
If those resources were reported out, then
Sure.
perhaps you could share those with the whole group.
Yeah, absolutely. Absolutely.
I just think it's worth trying.
Okay. Yeah, we can absolutely do that for like the last 2 to 3 sessions. We can try it, get some feedback each time, and yeah, no problem. I see some other people, Dawn, liked it. So we can give it a try. Let's give it a whirl. We'll do that in March. So with that means we also need a case or a discussion topic. So please be thinking about that. If you have something you want to discuss, it doesn't have to be related to the topic that's going to be discussed at the session. Please feel free to submit it for that next one in March. The other thing is, if we do the breakout rooms and things like that, we really want to encourage people to put their cameras on. I know that is not always an option, whether you're in a public space, things are going on. Totally understand. If you're eating lunch, we don't care. If you care, we understand. But if we don't care, plenty of Zoom calls where people are eating lunch nowadays. So please, if we do the breakout rooms, let's try to have our cameras on, because that'll help. The last thing we want is to have people on there and maybe not have their cameras on, so it's harder to facilitate those rooms. All right. I am going to put the evaluation link in the chat, but again, you also get it in the recap. So if you don't click on it, no worries. But we'll plan on seeing everybody March 7th at noon. All right. All right, everybody, take care. Steven, Sam, Kendall, Rebecca, thank you again. We really appreciate it.
Well,
Take
thanks
care,
for having us.
Yep.